Welcome everybody just joining us. Welcome to our webinar today. I'm just going to give it a few more minutes for a few people to join us because you can see the numbers starting to grow. So get yourself comfy, grab a drink. You've got about 60 seconds and then we'll look to get started. But welcome to all of you who've made the time today to come along. Great, so we've got a good number of us on now, so I'm going to kick us off. Hello everybody, welcome to our webinar today. I'm William Roberts, I'm Chief Executive here at the Royal Society for Public Health. Today's webinar is going to be really exciting and interesting. In a moment I'll introduce our speaker who's here with me. But for those of you who are joining, a few pieces of housekeeping. We've got a Q&A function, so if you've got questions you'd like to put to Jim, please put them in the Q&A and we'll go through them as we do. There's also a chat function if you want to get in touch with us. The webinar is being recorded, so if there's anything you want to watch again or things that you'd like to see, it will be available afterwards. If you have any technical problems, again, please put them in chat. If for any reason Jim or I disappear, we'll endeavour to keep going and one of us will soldier through, but we're not expecting to not be able to keep going today. So kicking off today, I always say this on our things that our speaker doesn't need any introductions, but I'm going to give him one anyway. But I really don't think Jim does need an introduction today. Professor Jim McManus is the National Director of Health and Wellbeing at Public Health Wales. I think it's also fair to say, from the sheer number of you who have dialed in, Jim's also one of the really good guys, truly engaging speaker, quite inspirational to many of us. I know that he has been a real support and mentor to so many people in public health over the years. He's also a genuinely thoroughly great person to spend time with. I can attest on that. I have some of my best and most engaging chats with Jim. So I'm really excited about today's webinar. And I know all of you are who are on there today. We're going to be looking at the issue of inequalities particularly. And I can't think of a better person to talk about that. So Jim, just to kick off and warm you up, it's great to have you here today. Perhaps just start a little bit. I think you have quite an inspiring story about how you came to public health. So perhaps just to give us a bit of a story as to how you ended up being the National Director of Health and Wellbeing in Wales, but also a little bit about why particularly inequalities for you.
So I guess start with the last one, and it's great to be here. Inequalities for me is about making a difference to people and about kind of justice and valuing justice. And my mum was a factory worker and my dad was a bus driver, and my granddad was a miner, and we grew up in a fairly poor area of Scotland. And when I go back, I mean, most of the people my age are either dead or severely disabled with long-term conditions, and lots of people at work. So it's kind of personal, and it's based on the values I was brought up in to make a difference. If you don't make a difference, you're not doing it. And I kind of fell into public health because, so my undergraduate degree is in theology, right, which, is actually a really good preparation for public health for some of the things like philosophy that you learn. And ended up working in local government, then the voluntary sector. And someone said to me, you're really a public health person. And at that point, public health wasn't open to non-medics. And so I worked in the voluntary sector. And when it was opened, I became a consultant in public health, got on the register, and have always looked to work where I could make a difference. And the Welsh job came up just after my mum died. And I'd looked a few times at working in Public Health Wales because I think they're really exciting. There's lots of stuff to do. And after 11 and a half years in my job in Hertfordshire, which I loved, and I have a great team there, they're awesome. I just thought, well, this looks like somewhere I could go and am meant to go. And luckily for me and unfortunately for them, I'm here. And it's great. And there's so much to do. But and it uses every ounce of you, I think. So that's it in a nutshell. Otherwise, I'll talk all day.
Well, I think people have come to hear you talk all day, Jim, so don't be ashamed to do that. And like we've talked before about some of the challenges we face. Why do you think it is that we're facing such an acute set of challenges, particularly around social justice and inequality right now? Because I look back to 170 odd years ago when my organisation was founded. I read the things people were saying then. They were talking about pollution in the rivers. They were talking about poorer people dying younger. They were talking about poor quality work in workhouses. They were talking about, challenges around food hygiene. They were talking around, issues around human movement. So why do you think 170 years later we still have many of those problems and we've not been able to really tackle inequalities as an issue?
I think there's several reasons, and one of the reasons to me is that we need to look for complex, not complicated solutions. When one of the things I learned when I did my theology degree was about complexifying things. And that means basically lay the different bits out on the table and work out how they relate to one another and work out how to shift them. These days, people call that systems approaches. And a very dear colleague and friend gave me a little leaving present when I was leaving Hertfordshire, which was a book called Aids to Public Health. And it could have been written yesterday. I opened it. I didn't look at the publication date. And it talked about all the things you just mentioned. And the publication date was 1923. And I think there are several reasons. One is that we're too short term in how we think as a nation and as a system across the UK as 4 nations. Although I had year on year funding in Hertfordshire, I was still able to think in 10-year timescales of what I wanted to achieve. I think the second thing is too often the systems we create at the level of the citizen don't join up and actually make things more difficult rather than easier. And I've spent too many evenings in, supermarket community rooms listening to kids for whom the system has actually caused additional problems, not helped them. So I think we need to redesign and reinforce. I think the third thing is we have seen significant secular, by which I mean generational changes in job expectations, skill set, which has marginalized and widened people. So what Walness talked about in 2002 has happened. I think the third thing is the environment, the commercial environment, the actions of commercial actors are almost against us being as healthy as we can be. And I think the final thing is actually the kind of we know that the kind of fragmented society that we're in is actually not good for our health either. And so we've added things that will make our health worse rather than actually address some of the systemic things that will make them better. It's not all doom and gloom, some things have got better. But I do think we need, to look at the whole system that mitigates for our health. And then finally, climate change. The people who are the poorest are the ones who have the worst impacts of climate and the worst impacts of the chemical industry and everything else. So I think there's all of those things that you have to work out what you can do and what you can change. I think another thing is we actually do too much to communities and not enough empowering of communities. And I know that sounds glib and trite and easy to say, but we actually really have to, people with HIV were managing themselves long before effective drugs came along, right? We've just celebrated, was it last year, 20 years of peer support for people with HIV for an HIV charity I'm an advisor to. Why haven't we got that same level of strength and ability in every single health issue?
Yeah, it's a good question, isn't it? And I sometimes wonder with HIV, particularly, I mean, my clinical background's in HIV, and I wonder if, in part that's because nobody else wanted to touch it, and so the community kind of had to do it because without them, who was going to do it? There were some brave clinicians who went and worked with that community who were real, um, trailblazers, but actually it was interesting that governments weren't that interested, health services weren't that interested. I mean, if we look at the findings of the infected blood review, actually they were almost ignoring these issues. And I just wonder if there's something about this challenge for public health about we really want to improve things, we want to make the world a better place, but we're also quite paternalistic with that. And then also that thinking about that in opposition with things like the commercial determinants of health and climate change that require systemic, almost multinational actions rather than local actions. I mean, how do we balance that circle of us wanting to change the world, not becoming too overbearing, and giving communities the chance to own their own health? How do we find those balances? Because that's tough, right, in inequalities terms.
I think it is hard, but you can do it. And I think the first thing is, uh, I remember when I did my first counselling skills course back in 1986, and it was this wee psychiatrist from the Southern General Hospital in Glasgow walked into the room, took off his glasses, and looked at us and went, "You lot are all here just because you need to be needed." So once every set of buttocks in the room had clenched, and we'd all gone, "Ouch," he had a point, actually. So I think you have to recognise that helping people is actually also partly about your need to be needed. And that's fine as long as you keep it in the right place and you know what to do with it and you don't become overbearing. You then have to work out how you walk with and encounter and serve. And the old ethos of public service, I think, has a lot to offer for it. You're serving people, you're actually supporting them. And that means you have to listen to them. And a principle of participation. I think unless you somehow engage the people who are going to be using what you're doing, you will get it wrong. I think one of the best things I ever did was redesign a community heart clinic when I was in the NHS. And the patients took our designs and went, "Well, they're a load of rubbish because actually we'll be walking along corridors with our bums showing." And and so on. So they redesigned it. There's a wonderful program in Gateshead called Edbert's House, and I think they do community engagement really well. They do a number of things really well. The DPH, Alice Wiseman, and Sarah, who's the chief exec, are kind of like, they're like fish and chips, always together and never out the papers. And they do a brilliant job of that. And I think you have to start by having a mindset of participation, having an agreement about what it is that's different, but also actually realizing that there are assets in communities. So the work we did with travellers in Hertfordshire over a number of years, and the team did this great piece of work on vaccination uptake. What they realised was there was a huge amount of capacity and organisational skill in the traveller communities. It was just that they didn't trust us. So how do you leverage that rather than go in with the solutions? And sometimes I think the scientific bits of our public health brain make us go in like boffins who think we know the answer to everything. And in fact, actually, we need a bit more humility.
Yeah, I think that's a really good point, isn't it? And I often say that change happens at the speed of trust, doesn't it? And so you build the trust, you build the relationships, and then change can happen. I guess though, you stayed 11 years in Hertfordshire, which is fairly unprecedented. We know turnover in public health directors is relatively quick. It's tough job. We know the average life expectancy of a chief executive in their job is about 2 years in the NHS. So how do you overcome this idea of like kind of the churn in public service versus the time it takes for the things you had? I mean, you talked about long-term thinking, but few people are blessed with a leadership and a political environment and a community that's willing to wear them for 11 years to let those things happen. So what are your kind of thoughts for those on the call who maybe are having huge turnover, lots of changes, about how they can build those relationships both with communities but also with other professionals? That you talked about collaboration being a key part of the future. So how does that work in your mind if you're not somebody who's got an 11-year DPH?
I think you, if you look at a local community, the people who are always there are the local councillor, the local GP, the head teacher, the parish priest, and the convent, if you've got one. And their mindset is to flourish where they're planted, right? And I think you have to flourish where you're planted. I've done short-term jobs as an interim, and I have to say that some people find them really satisfying. I don't. I think I like to make a long-term commitment. Um, and you can see things change and grow over a period. And the thing about health inequalities in public health is nothing happens so quickly that you can see results overnight. You have to be in it as a commitment for the long term, and it's as much a philosophical value and a heart thing as it is a scientific thing of being there. So, have you got a settled will that you are, if you like, called to be in this role, in this place, doing this job? Because if not, then maybe think of going somewhere else. Um, I think the second thing is year on year funding has been with us for decades. But I worked under chief executives who had 10-year visions, and it's about the mindset. And I would say, what is it you want to achieve with your community? And then the third thing is go out and build a movement. So my first day in my last job, the elected member said to me, she says, I want you to build a golden age of public health in Hertfordshire. And I thought, oh, that's easy then. Thanks. Cheers. But she was right. She said, and I thought, right, well, I can't do this. I'll go and build a movement. And if you look at Wales, by God, there's some fantastic people doing things, and we have the ability to. If we in Wales align ourselves in the right way, we can change the world. We really can. I really believe that, and I think it is about consistency and stability and persistency of outcome and flexing your tactics. Now that can be quite frustrating for people, I know, but that's what I've learned.
And that sort of nicely leads on to a question. So, those pieces about sort of the consistency, you know, how do you feel when you've got these communities who perhaps don't have trust? You gave the example of the traveller community. We know that they don't trust people in positions of power because they've been systematically, harmed by those people over the last 200-300 years. So how do you build that trust with those communities when they're perhaps not really that interested in you? They want to have control, they want to be better, they want to be empowered, but they equally, you know, day one, Jim walks in, says hi. How do you go from there? Because I think for a lot of people on the call, they want really practical solutions. So what would your advice be to somebody, starting out on that journey about building trust?
Listen more than you talk. Do what you say you'll do. If you're not going to do it, then tell people why and the reasons you can't. Don't promise things you can't do. I mean, we all do that. I do that. I remember I was in Cardiff at a meeting at Cardiff Met University, who are wonderful. We've got an amazing health and physical activity and sports centre. And I was getting the bus back into Cardiff, and I managed to go to the wrong side of the road, and eventually got on the right bus. That was my fault because I wasn't paying attention. And I had my lanyard on, and a woman on the bus looked at me and just looked at me and went, "What you see here, lot?" So I took this as my first citizen examination, sat down next to her and said, "Well, hello, I'm Jim. Tell me, what do you think?" So an hour later, when we both missed our stop, uh, it was a case of listening and taking them seriously and acting. And if you can't do it, why? I think trust is something that, as a public servant, you earn by what you do and by the mindset and by the respect you show people, not by virtue of any power that your intellect or your position gives you. And I think learning from elected councillors, there's a great the best of elected members, and I've worked with some amazing ones in every job I've been in. They will show you, I think, the way to approach and listen to communities.
Yeah, and you talked there about, you talk quite a few times. You've mentioned sort of the good stuff they've done in Wales, and you've seen. I mean, I think there's huge amounts to learn, particularly from the devolved nations. And I think there's a tendency, particularly in policy terms, I think sometimes in public health terms, to think from a very English-centric perspective. What do you think are the things that, having gone from essentially an English council and a national role in ADPH as president, across the four nations, what are the things you've really learned about yourself, about inequalities, and the kind of how to get stuff done from going to Wales in your sort of relatively short time there so far?
So I think Wales, one of the great things about Wales is that you have a world where people don't want to tell each other what to do, which is perfect for collaborative and system leadership development. And it's very different, I think, from England, and also different from Scotland and Northern Ireland. I think the thing I love about England was the strength of local government as a public health force. And if I could wave a magic wand, the strength of Welsh local government as a public health force we'd recognise much more. And I know we've got great colleagues in the Welsh Local Government Association, and we want to work closer with them. And we've got a number of programmes with that. So first of all, I think support local government to become public health organisations by building on what's already there, not kind of going in with a deficit approach. I think the second thing is public health, wherever it sits, can make a difference. In England, it was right for us to be in local government. In Wales, we are where we are. In Scotland, we are where we are. Let's not let's not mess about with shifting goalposts and this obsession with reorganisation, because nowhere you sit is perfect. It is about collaborative leadership. And I think it's about winning hearts and minds and getting things going. Um, and and also about being clear enough to listen to criticism, listen to people's views, but at the end of the day, weigh it all up and make a decision and go with it, and look for change and look for difference in people's lives, and be clear what will be different as a result of what you are doing, even if that will be a difficult ride for some or for everybody. That for me is what I've learned. I think the other thing about if you look globally, we need to stop centralizing quite so much as the United Kingdom. The British system has always, over the last 60 years, worked in a bit of a closed system where one agency doesn't necessarily talk to another. And we've also kind of been very, very centralized in terms of decision making. Actually, the more we devolve locally, often the better. And national bodies then become enablers, a very clear rule about what is it you can do, what is it locally you can do. I can't do my job without the 7 directors of public health in Wales. I'd like to think they can't do theirs without me and my team doing ours. And it's about making that a reality and having honest conversations. Does that make sense?
I think it does, and it touches on a question Andy's asked in chat, which is about kind of what do you need centrally to make effectively devolution, local government really work? I mean, from my perspective, I think it's interesting. I think we go through periods, don't we, of contraction and then localism, nationalism, and it look over 200 years and you see this happening all the time. It's a cycle. What do you think, though? We quite often get this wrong. It's either or, it's either very centralized or it's very localized. What do you think are the key things that you've got to have at a national level to really enable that local to thrive? Because we've seen some good examples of this, like you say, in Wales. I think there's some great examples in Scotland. We've seen some good stuff, I think, in Greater Manchester, West Midlands. You've talked about the North East, and there's some great stuff going up there. But what is it that's making those things work in your mind from a central perspective? Because it isn't just give all the power to the local, is it? There has to be some stuff, particularly in public health terms, that we still do want across a nation, if not across, 4 nations and indeed Europe, the world.
I think it's, from what I've seen, you can see in some systems people at national level who are asking the question of what is the value we want to bring? What's the outcome we want? Right, who's best placed to do that? And you go from there, right? How do we get everybody involved and participating appropriately? And those people behave a bit like orchestra conductors. They know which role each bit of the orchestra will play, and they orchestrate that group of people. And it's not this level will do, is more powerful. It's this level has skills and assets here that only they can do, and this level has other assets. There was a book I read, oh Lord, back in 20 odd years ago now, and it was about intersectoral collaboration in the private sector. It was about private sector partnerships. Best book on partnerships I've ever read. Because what I learned was that private sector partnerships pursue value, otherwise there's no point. And they identify the value, they identify who's best
Yeah.
at delivering it, and
Yeah.
they ruthlessly, if they're profitable, pursue the value. What do? We shove a whole pile of thousands of pages of paperwork and guidance and legislation in the way without actually thinking, is the NHS or is local government better at doing this? Or is national government or is a national agency better at doing this? And no offense to English colleagues, but I sometimes think that conversation is easier to have in the Celtic nations be, because of the constitutional nature of the way the system has been set up. It's not a piece of cake, and there are things England are doing that everybody else should learn from. But it seems to me the commonality is that mindset of value and then function, not a mindset of status and locus.
And it's interesting, isn't it? Because I think, there's a good question from Meg in the chat about, how do you balance what you're describing as a long-term thinking and being visionary and a leader and playing the long game when actually a lot of what comes down to us is about the solving here and now. And and similarly, Rob has talked about the sort of the over-reliance on individualization of risk, and this needs to be about helping people to just eat a bit less and smoke less and exercise more, and then lo and behold solve the issue. How do you balance off those kind of like when you're under those real pressures of a system that tells you it's about individual responsibility, governments wanting to clear waiting lists, financial pressures, with this kind of holding this long-term vision? What have you done? What would you advise to people on the call to just manage those real tensions?
Um, so my first hour every Monday before everybody turns up, and my last hour every Friday after everybody's gone, is to sit down with a bit of paper and go and which has my what do I want to achieve over a year, 3 years, 5 years, and 10 years in it, and just check where I am on track with that. And I find that as an incredible sort of way marker for the week. And there's not much that I can't fit into a long term view. If you think of what Sir Chris Whitty said, that the thing about public health is it's the area under the curve that adds up of behaviour change. Um, so it's the cumulative gains and wins. That's always a long term thing. Um, uh, Getting waiting lists down is a good idea because actually it means the NHS can be financially sustainable. If you get waiting lists down as a public health person, that is about improving health and improving function and stopping people becoming more ill. You can incorporate and collaborate the two. And I think it is about your mindset of how you approach that and how you do that. Um, and sometimes it's just about using different tools to analyze the work that's coming across your desk. There's a great tool called reverse planning, which the Germans use, Amazon uses. So if you're trying to achieve X by 2029, you actually start by visualizing yourself on the 1st of April 2029 and work out what's different. And then you plan backwards. And some of the colleagues in my dental public health team have been looking at this and come up with some really interesting insights, I think, that I would like to do more on with them, but haven't as yet. So that's my fault. But you plan backwards and you inevitably find that every single plan you got is a complete failure. And you have to plan forwards again and plan backwards. And then you adjust it. And I think it's about um, thinking in several dimensions. Several people have said about me, I think in several dimensions, and one of them has to be temporal. So that's worked for me. It may not work for others, but when I can point to the projects in my life where I've made a difference, that's been in there.
Yeah, I think that was it's 7 habits of highly successful people. I always say to people, start with the end in mind, which is the one I always like, because I think it's that idea that what are you trying to achieve? How do you hold that vision? and then what's got to happen between now and then. You're right. I mean, gosh, the number of plans I've written that have never happened or never delivered. But I think what's interesting is when you have that vision, you can really plot towards it, and you can ask yourself the right questions of, is this worth my time? I was always struck when I worked in the health service by how much value was placed on meetings, and so it became a currency almost, so people would talk with real pride about being in back-to-back meetings. But when did you do the work was the question I'd always ask. And I think there's something interesting, isn't there, about us calibrating our brains a bit differently to what good work looks like. Yeah, I'm going to touch on kind of the future now. A lot of people have asked is obviously we're in a period of purdah, so I'm not going to ask you or to give any view on any particular politics or any particular party. But if you were tomorrow magic wand the minister in all four nations for health, what would be your top three things you'd be saying to your respective first minister or prime minister?
Leadership and mindset. We spend lots of money as a nation on all sorts of things. How do we get the best value out of that money that we're already spending? How do we get more preventive gain? I'm going to avoid anything that might be seen as breaching the pre-election restriction period. But I think public health at its best is an exercise in leadership for change using a range of scientific techniques and technologies to get there. And most senior civil servants that I've had the privilege of working with, and most local authority chief execs similarly, actually see that this is a leadership exercise and a change exercise. So invest in the kind of leadership that can understand the complexities, that can vision and can adjust, that can provide way markers on the way, and that can harness and orchestrate these varying systems. Now, that might seem an odd place to go, but I think for me, that's about what will make the difference with the existing resources and people and skills we've got. I think there is something about redesigning the world of work for many of us in terms of the meetings that we're all in and providing people with thinking and doing time. But if we could do that, I think we really would make a difference. That I'd probably go with that as my top priority, because I would have about another 75 underneath that. I think the other one would be actually we really, really need, I think, to create an environment where people are pro-social to one another right across the lifespan. And I don't want us to go back to the 1940s, where we're all having, booze ups around the piano. But what I do want is a world where everybody knows who are the people that they can talk to and exchange a smile with, because that really does make a difference. And I know the benefit of that from the communities I belong to. And we know in other nations that really has a strong foundational motivational thing, both for psychological health and for social health. And it also helps people regulate actually some bits of their lives if it works in the right way.
I mean, I guess that touches a little bit on a question that was being asked by one of the audience members about sort of your views on sort of how social media has both changed some of these challenges, in some ways made them harder, but also what some of the opportunities might be of the internet, social media, and the challenges we face as a nation around connection.
I think it's a good. So I love using Twitter to get journal articles and do CPD, and I have been known, right, to print off a tweet thread and put that in my CPD reflective notes, right? So I can't lecture anybody on it. And it works. But I think if we can stop assuming that social media is reality, because it isn't, and put it down. I think you do need time off a screen. It does change your cognitive structure. Um, the algorithms will change the way you cognitively process information, even down to actually reducing your attention span. In some cases, there is some evidence of that. So I think you need physical connection. I grew up in a village where you said thank you to the bus driver when you got off the bus, and if you didn't, you got a slap round the back of your head from your mother or anybody else on the bus from the village. Um, Encouraging people to actually talk to one another, encouraging people to kind of recognize one another, exchange eye contact. Um, in those nations where they do it, and there are studies about this, it does show that it makes a difference. So how do we do that? How do we encourage people to have a conversation? Social media is great for people to reach out for help when they need it, but actually you also need that level of human contact, and I think we need to encourage people to do that. I've got no easy answers. I think the two books that have recently been written on social media as the cause of all anxiety, twaddle, frankly, um, doesn't stand up to scientific scrutiny. And young people are not experiencing a mental health crisis because of social media. It's far more complicated, far more enduring, and far more threatening than that. Um, and social media is not the only cause, not the biggest cause, and it won't be the only solution either. But how do we get people to do things like reading? Again, the benefits of reading. There's lots of evidence around that. How do we get people to connect in circles and talk to one another? And maybe one of the things about our workplaces is when you bring people together, build in time so people can talk to one another. There's no point going into an office if you're just sitting on Teams all day. Go into the office and build in time for some social contact.
Yeah, I know we've had that conversation, which is, we predominantly aren't an office-based organization, but when we're in the office, we have to maximize it because what was the point in coming to the office? If we're just going to sit on Teams, let's sit on Teams at home. So there's something, isn't there, about I think that intentionality of how we have these tools. These tools give us amazing opportunities, but we've got to use them responsibly, and we've got to think about the harms they may cause, but also I remember something I heard recently where somebody said, well, why isn't, safety the default setting? So you would never set a car up so you could drive it at 200 miles an hour from start go and you wouldn't have it. And so why do you have to opt out? Opt into all the safety features rather than opt out, which I think would be an interesting debate for social media. I'm going to just, there's quite a few people who ask questions, so I'm going to give them a go because we've got, the hundreds of people that have signed up for this. We should give them a chance to ask their question, right? So I've got a question here from Grace. She said that you said that we need to support local government to become public health organisations. What practical advice would you have for making organisations more public health focused at a sort of, consultant in public health or director of public health level?
A good 25 years ago, the British Psychological Society had a year of giving psychology away. And I remember going to one community organisation and said, well, if you don't like it, can we give it back again? And it was arrogant and it took a deficit approach. And I think you have to start by going in to listen, learn with your ears and eyes open and understand the assets that are already there. So local government was set up as a public health organisation in around 1848, the first Local Government Act. There are tremendous public health skills in local government. It is about finding them and finding and understanding how they do it and understanding ways of enabling them to make an impact, but also harnessing the impact they've got. And one person is not going to make a difference across the 2,578 statutory responsibilities of a local authority in Wales. I think, if I've got that right. Or in the 2,419 in England, as it was. Actually, you create a movement. You win hearts and minds. There's a guy called Ralph Stacey who talked about organisations as being complex social processes. I think he's right. So you basically go have conversations and you win hearts and minds and you get people to identify what they're doing and you build the environment in which public health can flourish. And then you can come in with tools and things that will help, like evidence. I remember one person saying to me, well, the trouble with local authority engineers is that they don't understand randomized control trials. And I said, well, we don't have them for bridges, but on the whole, the ones the engineers build around here stay up. So can you just wind your neck in a bit? So I think understand what value is there, understand what you can take out of it. Don't be so arrogant. I mean, we've all done that. I've done that, and by God, I wish I hadn't done some of the things I've done. And have a plan for what you want to achieve, and start with someone who's willing. What public health difference can you make in early years? What public health difference can you make in even just in road safety? Pick something, work on it, build the movement, and get councillors on board. Elected members are the sleeping giants of public health. They really are. Enliven them. And I have to say, most of the stuff I've ever achieved in local government has been because members have given me honest feedback when I've been doing things wrong, and honest feedback about what I have to do right. And, the cabinet members I had were just awesome. That would be my advice, my experience.
I like that. So I've got one here from anonymous attendee. Obviously, they come to all of our events, regular question asker. So somebody's asked, how do you start to address some of those fragmented funding practices across the different health systems? This is a real challenge, isn't it? That you have differences, different parts of the system hold the budget, different parts of the system commission different things. It changes from organisation to organisation. What's your advice to people practically on thinking about, we know how to tackle inequalities, we know who the people we want to target, but often these kind of funding streams get in the way. So what are the things you would advise people to do to start to address some of that?
I think this is one of those things where you need a really good commissioner or a really good planner for those nations that don't have commissioning markets. And I've been lucky all through my career in that I've had really good ones. And give them their heads and let them join up money and join up funding streams and join up work. And I'm just thinking of one person in particular who got funding from NHS, from district councils, and from us, and worked on a project which joined everything up. And thinking currently of a project in Wales where one of my teams has created a national role to do a whole load of dietitian work on diabetes. And she's got money from the network, she's got money from us, and she's done a brilliant job on that. So I think it's about look at the problem, identify who's got, have a whip round, pool the money. The legal powers allow you to do this. Every nation has got legal powers to pool money, and get a really good person who knows this to actually plan it and deliver it.
Yeah, the tools are all there, aren't they? And I think they're hugely underutilized. I remember using Section 256, 257, one, you name it, there's a section for it in the Local Government Act. The one thing they've got there is a lot of legislation, was my experience of working in local government, and we just don't utilize those things, right? Specifically to think about how to open up some of the things. We see them almost more as barriers, I'm guessing. But do you find, this is all really progressive and exciting? And lots of people, I guess, will be sitting here going, well, yeah, of course, I'm sure that's great if you've got a gym in place. Is this about having brilliant people like you, Jim, or is this doable anywhere? I guess is my question.
I genuinely believe if I can do it, anybody can do it. I think what you need is the right what we might call an authorizing environment. Now, the Australians are big on the authorizing environment in public sector. So if you Google authorizing environment, you'll come up with a lot of Australian reading. And basically, you need to work out what you want to achieve, work out who can help you, work out who can stop you, work out the building blocks you need, and then create a plan. So in local government, you need a lawyer who will help you navigate it. You need a commissioner. In the NHS, you need planners, you need funders. And then you need to win hearts and minds. And then you need to kind of persuade people. And often some people will be turned on by the science. Most people, in my experience, are turned on by the difference it makes to them and the difference it makes to the lives of the people they serve. And that, yeah, I'm sounding like 100% optimistic. That doesn't mean I haven't had massive failures. It doesn't mean I haven't had projects that have failed massively. But I maintain that hope and keep going will win, and it's done that for me every time.
Lovely, and I agree with you. I think we have to start looking at a hope-based thing. I mean, there's lots of things that aren't working right now, but unless we actually offer something more positive and hopeful, I think it's just essentially a doom loop, isn't it, for systems, because you just talk yourself into failure. Sean's asked a question, which I guess is specifically about town planning, and at the same time as planning and public health hugely linked, and we've seen huge cuts in town planning resources. I guess you could ask this question about a number of things. I think trading standards, environmental health. We could probably also have that conversation in a range of other public sector organisations. How do you think people can start to address some of these issues of really quite deep reductions in both staffing and workforce for different parts of the system that aren't necessarily directly health or public health, but contribute hugely? What's your sort of advice to people on how to do that? Because there isn't a sudden pot of additional money that's going to come in the short term, is there?
No, and I think the people like the Health Foundation and people like ADPH and the Local Government Association in England and COSLA and WILGA in Wales have said for ages that you need to understand that there is a basic foundation to public services without which health is harmed. And that foundation is typically local government. And you need, I think, to argue for the sustainability of the basic functions of local government, without which you won't have services. Now, that's a long-term thing. I think one of the things local government is actually more successful than the NHS at saving money. But there comes a point when you can't cut anymore. And this isn't a political issue, it's a constitutional issue. So I think we need to look again as a nation at how we fund the basics of what local government does for us and build on that. I think that can only happen by the public health profession adding its voice to the local government profession and to everybody else to say, look, this is what we're buying. And Wanless said in 2002, unless you buy certain things, if your population is too ill to get off the sofa, it's not going to compete with China, if
Yeah.
I'm putting it that bluntly. And that is where the NHS is not a service that can deliver an answer to all of the health problems we have. It takes everybody.
Yeah.
And I think that means we need to go back to who can do what and actually argue for the funding and create the economic cases. And I mean, real economic cases that stack up with Treasury.
Yeah, the 2.8 million people who are economically inactive is a huge population, and they're too sick to work. And it's not a case of those people not wanting to; they are just too sick to work. And when you look at those three reasons why they're too sick to work, some of that is to do with what's offered to them in the workplace, some of that's to do with their own health, and some of that's to do with the services they have in the community. I think, and I think we have got to get more honest. I think about where it plays to different parts of government decision making, doesn't it? It can't always be just about this is the right thing to do. But we'll come back to a question from Ben on that in a moment, because we'll talk about that in a second. So one question from Nigel, and this I think leads on from what we've just been talking about there, is you've talked there about local government. We know alongside that, the voluntary community organisations have had massive reductions in their funding. Many are going to the wall. Do you think we value them enough? Do we think we understand their impact enough in the system? That feels a bit like a rhetorical question, Jim, but do slap me if it's not.
um, so you'd probably expect me as a trustee of a couple of charities to say no to that, because I do think we say no. And I'm a trustee of a hospice, and we developed a heart failure service that actually cut hospital admissions, and then we couldn't get funding for it. And the hospital admissions went back up. And we need to recall, actually, the voluntary sector isn't care on the cheap, and you can't do everything with volunteers. You need to pay for it, and a good, well-funded voluntary sector doing the right things is actually a crucial part of a social infrastructure. So if you look at the question from Ben and the question from our colleague about commissioning, and you look at sexual health would be in dire straits without the voluntary sector, right? If you look at monkeypox, when we were arguing about vaccines, people like the Love Tank and Prepster were out there getting people in who are in real risk. And once again, with the health of LGBT people, the voluntary sector came before anybody else did. And we don't learn that. So I think we do need to understand how we work with the voluntary sector better and how we develop really good funding models for that. And I think there is a moral issue that runs all the way through this, because actually a healthy population is a moral good in a civilized society. That was defined by Sir Joseph Stair in 1695 when he wrote his books on the laws of Scotland, which of course we've all read. Maybe just me then. But he defined health as a moral good. So I think you have to see every actor who wants to build health as participating in that kind of what Sandra Galea, the public health professor, would call the exercise of love at a population level. It is a moral thing. I think what that means is that we need to look seriously at whether the systems that we are putting in place in terms of funding are actually putting our money where our mouth is. And to me, what I've been involved in the voluntary sector since I was 14, and it's always been like this. It's worse in the last 30 years, funding wise, but I don't think we've ever had, as a nation, the kind of, as a United Kingdom, the appreciation of the voluntary sector we think we've had.
Yeah, I'd agree with that completely. I think it's a huge part of our national infrastructure. And if we talk about it from a resilience perspective and a safety perspective, people would take a very different view. A bit like your bridge analogy, that you wouldn't just take away the stanchions from a bridge and expect it to stay up. And I think we do that with the voluntary sector a lot. So I'm going to ask you a couple of quick questions. You and I have spoken quite a lot. I love the way you use words like love, hope, kindness, generosity, things that are very unusual in I think in public servants. We don't tend to talk like that. What's your view on the issues around kind of like the morality of health inequalities, the moral argument, if you want? Do you think we use it enough? Some people have critiqued it for saying this isn't just a moral argument. Others have said, well, hang on, if it's not a moral argument, why are we not talking? Where's your view on that kind of piece about, this is the right thing to do versus this is the economically advantageous thing to do or the politically expedient thing to do?
So when the public sector in the United Kingdom was being created over 100 years ago, or being formalised into, formalisation of local government in 1843, it was a moral good for the health of the population. And it came from very strong moral principles. And I think one of the things about public health is actually our values are all philosophical or moral: equity, justice. These aren't really scientific values. They might be scientifically informed, but if we're really honest with ourselves, they're moral, philosophical values. And I think the problem is our account of them is philosophically thin, right? An atheist friend of mine says that the best thing he's ever written about justice is Catholic social teaching, the 7 principles of the dignity of the person, the right to participate, subsidiarity, decisions are made nearer the person. Other frameworks are available, but I think we need to articulate a philosophical framework for public health, which gets beyond this analytical Anglo-Saxon philosophical obsession with individual ethics and actually starts learning from the European and the global majority heritage of social justice, community, and social connectedness. Philosophically, I think our public health world is in the wrong place, because it's constrained by Anglo-Saxon analytical philosophy and utilitarianism, when we should be actually looking at human flourishing. So that marks me out as an Aristotelian anatomist. But I think the good thing about public health is that we can scientifically inform those values. Now, Sandra Galea has written about love. Avedis Donabadian, the founder of healthcare quality science, talked about good quality healthcare as being an exercise in love at a population health level. We shouldn't be embarrassed about talking about loving our communities, because it keeps us connected to people. And it's also a good antidote to the paternalism that, too often we see. And one thing you learn from long working in safeguarding is that is that that paternalism and a process, not values, is one way of devising systems that kind of instrumentalize people rather than help them flourish.
Lovely. So a couple of last questions before we finish. There's so many I could keep going all day with this, Jim, I have to say. And I think a few of the comments we've had suggest other people would like that as well, but we have got day jobs to go to as well. Quick question, public health, is it too elitist?
I remember when I joined, I remember someone saying public health, because I'm a non-medic, and saying, and I went through the portfolio route, and I got advised to take the faculty part in part, well, it was part one and part two then, exams, so nobody could call me an epidemiological lightweight, and I did. So I think sometimes, yes, we can be a little too elitist. One of the things about public health is that it's nicked every possible science to use in the pursuit of human health. Why? I mean, great. So let's not be precious about that because we've got a mindset. But I think we do need to make routes available. We've got a workforce crisis in public health. We've got many people who could be doing really good senior public health jobs with the right level of training, and I think we need to create the routes for them. I think when I joined, I felt very much a second-class citizen, and you can imagine what my response to that was. Um, Someone said to me, "Well, what do you bring?" I said, "Well, actually, I'm a chartered psychologist, a chartered science. I've got a leadership qualification, and I've been in a management job for 10 years and worked in multiple sectors. What do you bring?" Um, so yeah, we do need to find ways of. I think you can't do public health if you haven't got medicine and all the other sciences and all the skills, all the talents together. How do we get that into public health? So how do we create? Perhaps you've got a royal charter as a Royal Society. Um, how do we create a chartered route to public health practice? That is a very old-fashioned British model. That's not the Royal College model. But chartered accountants, chartered psychologists, chartered scientists, that's a really good model. What can we do that can be looked on as a route to public health practice? So yeah, I think we still have some work to do in how we include people.
Yeah, I agree. And quick plug for anybody who's not read it, our Unusual Suspects report on the wider public health workforce talks about how do we start to do this, particularly pre-degree level. How do we start to actually think about the millions of people who would like to have a role or a career in public health who currently it's just not an option for? And that report offers some practical solutions. Please do go have a look at it and come and talk to us if you're interested in any of that. And I know ADPH and faculty have also been hugely supportive of that work with us, along with some others such as the Register and people in UK public health. So I'm going to ask one last question and then we'll have to close. Jim, last one for you. Given you are there in Public Health Wales, how will you lead, enable, and support Public Health Wales to more effectively tackle and reduce health inequalities in Wales? That's about a 60-second answer, I'm guessing, Jim.
I'm hoping by using the talent I have to make the talent that's already there more effective, and add my bit to value. And if I'm not doing that, people are welcome to come and tell me. I've gone around everybody saying, if I'm not doing what I should be doing, come and tell me. Or if I'm doing things I shouldn't, come and tell me. So it's about adding value to what's already there, not about thinking I have the answers. I
I love
hope,
that.
and I hope I'm living that out.
I love that. So I'm going to just finish up. Normally, I'd finish up by thanking you and doing all the usual bits. I'm actually going to do something slightly different today, Jim. I'm going to read you a couple of the comments just from the things that people say goodbye to. So, firstly, for Andy, thank you, Jim, for continuing to inspire and encourage all of us who care about health, equality, and social justice. I have to go to another meeting, but want to say thank you to Jim for an engaging webinar. I would love to see a part two. So if there is people who want to see part two, let us know. We'd happily do some more. Meg said this has been such a fantastic session. Thank you. Nasreen, not heard Jim speak before, but it's been wonderful. Jim, I think they all speak as one in saying just how amazing you are as a speaker. I genuinely could listen to you all day. I love your optimism. I love your hope. I love the fact that you speak from the heart. Jim, this is a genuine pleasure to have you here again today. Thank you to the team who helped put this on. Thank you to you, Jim. And thank you to all of you who have given up your lunchtime today. It's been an absolute pleasure. But once again, Jim, absolute star. Thank you so much for your time today.
Thank you. Thank you very much.